Today we're going to look at pyogenic infections and infective endocarditis. So as give you a brief introduction of the topic, pyogenic infections are infections that produce pus. Pus came from the Greek word pyon. Pus, as you know, is a yellowish stuff that found in and infections. So, for example, you have pimples. Sometimes you see the yellowish stuff underneath at the lesion. So the pus is made of dead body cells, like white blood cells, and also surrounding cells, and enzyme and protein that being released from the light cells and generating that yellowish liquid. So there are many bacteria are capable of causing this pyogenic infections. There are two genera that we're going to discuss today. They are Staphylococcus and Streptococcus. So both of them are coccus, meaning both of them are round-shaped organisms. These are probably the most common type of bacteria that causing pyogenic infections. There are other bacteria, other genera capable of doing that as well, but we don't have time to go through them. So why do we pick these two organisms, Staphylococcus and Streptococcus? Staphylococcus cause a wide spectrum of life-threatening systemic disease, including infection of the skin, soft tissues, the bones, urinary tract, the lung, whatever you can name it. In fact, the whole body. Many areas can be infected by this organism, as well as this opportunistic infection. So you remember back in the mechanism of infectious disease lecture, I sort of highlighted this organism that it can be found in every part of the body: the skin, the conjunctiva, the oral cavity, and so on. So it sit there as mostly as a conventional organism, but you give them the right condition, they are capable of causing this variety of disease. Streptococcus is a large group of organisms, but we only focus on Streptococcus Streptococcus pyogenes, because this organism causes life-threatening disease. As we learned last lecture, it causes strep throat and scarlet fever, and then it can lead to rheumatic heart disease that can complicate dental treatments. So say a few more words about Staphylococcus. This is a gram-positive facultative cocci. So cocci, we know the term already, is round shape. Gram-positive, we know, is stained purple in a gram stain. Facultative means that is refer to the requirement for oxygen in growth. So you have aerobic organism and anaerobic organism. Aerobic obviously require oxygen to grow. Anaerobic will die in the presence of oxygen. Now, in between those two, you have the facultative organism. So facultative organism means that they're okay with or without oxygen. So they're happy with oxygen present. They are not also happy without oxygen. So that term facultative carry that meaning. In fact, most of the bacteria belong to facultative organisms. So the Staphylococcus, it has some characteristic when you grow them. You look at them under the microscope, they sort of cluster. Cluster means group together. Broad means liquid culture. So the picture on the right there, you can see a gram stain of the Staphylococcus aureus. you can see how the cells sort of round shape, but clump together as clumps, and a lot of time we sort of describe this as like a bundle of grapes, like you buy some grapes from Superstore or Sobe. It's just like a bundle of grapes. So they have that sort of appearance during growth. And the other, actually, the hallmark features of Staphylococcus is their ability to produce an enzyme called catalase. So catalase positive. Catalases are enzymes that break down hydrogen peroxide into water and oxygen. So this particular enzyme have that activity to degrade or break down your hydrogen peroxide into water and oxygen gas. Where you find this organism, or as a human, we already learned that it's found in many area of the body. So particularly relevant to dentistry, found in the oral cavity and the nose, the nasal, and also on the skin as well. It can survive for a relatively long time on objects, so your instrument, your bench top, and so they can survive longer than most other organisms. A relatively heat resistant as well, so it can, therefore these sort of factors survive long time, and heat resistant make it more difficult to eradicate. If you have not been colonized, you will be colonized by exposing yourself to contaminated objects or from another person, whether sharing food or whether from that sort of come in contact with another person. So I think almost everybody will be colonized by this organism. This one of the normal microbiota. So entry is typically this organism stay on the skin or the mucosal surface. So whether in the oral cavity, it stay in the mucosal, or in the respiratory tract, it will stay up the upper respiratory tract, like the nasal, they stay on the mucosal surface. So on the hands and body, you stay on the skin. So as long as it stay there, it's not will not cause any problem. But if there is a breakage or damage to the skin or mucosa, like for example from burns or insect bite or surgical intervention like surgery, they got the opening for them to get underneath tissue, and that is where they start the infections. So there are three important species within the Staphylococcus. The first one is probably the most virulent. It's Staphylococcus aureus. This organism causes more frequent and more type of disease than any other human pathogens. The reason why they can do that is they have the ability to produce many different virulent factors. So this can be grouped into these two categories, your enzymes and exotoxin, and then your surface components. So the enzyme and exotoxins, some of them are listed here. So these are not the complete list. So I had to put it there to illustrate a little bit. So you have a coagulase, which causes the clotting of the plasma. So you ask why they want to make the plasma to clot. I think that's probably something to do with it. They want to wall off themselves from the immune components. So they infect the site of infection at the beginning, they are not quite well established, so they produce this coagulate, so they build a wall surrounding that site of infection so they can limit the immune component to get to them. So that's I think that what people think that the reason why produce this coagulase. Then you have enzyme called hemolysin, leukocidin. This enzyme that break down RBC and WBC. Those are stand for red blood cell and white blood cells. So they sort of target these two type of cells in the body. So obviously, lysing white blood cell is important because they destroy the white blood cell, so they will not be able to attack them. Red blood cell contains a lot of nutrients like ions and in the hemoglobin, so they use that as a nutrients because iron is an essential element that make up your electron transport chain and other electron carrier. Then they produce a variety of enterotoxin. These are responsible for food poisoning. Staphylococcus is probably number 3 on the list of food poisoning. You have E. coli, Salmonella. You know them from hamburger disease, or people eating chicken or not fully cooked chicken. They come down with food poisoning. And Staphylococcus is another organism that cause food poisoning. So those 3 organisms, E. coli, Salmonella, Staphylococcus, are the top 3 organisms causing food poisoning. So in this case, the Staphylococcus virulent factor that causing food poisoning is the enterotoxin. Actually, about 5 of them, A, B, C, D, E. So these enterotoxins are quite heat resistant, so they cannot be destroyed by heat. So one of the interesting features about Staphylococcus food poisoning is that they don't need to have living Staphylococcus to cause food poisoning. So you have a piece of ham that had been contaminated during that incubation period. The Staphylococcus produce the enterotoxin, and then later on somebody come around and heat up the piece of ham, kill the Staphylococcus bacteria on the ham, but the enterotoxin remain in the ham, and that are not destroyed by the heating process. And you consume that piece of ham, you can come down with food poisoning. So that's different from E. coli and Salmonella food poisoning. For those 2, you require living E. coli and Salmonella to give you that food poisoning symptoms. Then this organism also produce another toxin called enterotoxin F. It's also better known as toxic shock syndrome toxin 1, so TSST1. It obviously caused the toxic shock syndrome. This toxin was initially discovered in a female who having the period, and the tampon got contaminated by Staphylococcus, and then that produced the toxin and then enter the body, causing that toxic shock syndrome. Then you have the exfoliative toxin. This is the toxin that causes the dermis to separate from the under layers of the skin and causing like a bubble looking, and this is in the Staphylococcus gall skin syndrome. Then they produce a whole bunch of surface component, capsule, extracellular matrix binding protein A. So most of them are used for colonization purposes or adherent purposes. Protein A is different. Protein A bind IgG from the serum, and the binding of IgG, meaning that the IgG will coating the Staphylococcus cell and then make the bacteria look like B cells. So B cells are the immune cells that produce the antibody before the antibody being released into the blood. The B cell carry this antibody on the surface. So by binding to IgG, Staphylococcus look like B cell and therefore can avoid the immune system. The second species is Staphylococcus epidermidis. This one is different from Staphylococcus aureus in that they do not produce coagulase. So the test that separate the two apart is doing the coagulase test. So Staphylococcus will be coagulase positive, and the epidermidis will be coagulase negative. Generally, this organism is not as virulent as Staph aureus, but quite significant in immune-compromised patients, especially patients with prosthetic device like a tubing going into the bladder, or a tubing that going into other part of the body, or in surgery, because this organism, epidermidis, as the name implies, means they found on the skin dermis. So it mostly found on the surface of the skin. So you have any kind of breakage to that skin, whether as a tubing going into the body or surgery, they will allow the opening for this organism to get in. The reason for it is permanent endocrine condition, and then obviously the other condition is immune compromise. One of the reasons why this is can cause so many infections in humans because it produces a large amount of slime or capsule. So this slime and capsule allow them to develop into a biofilm. Biofilm is the layers and layers of cell and other material, so bacterial cells and other body materials, whatever present there, build up the layers and layers, and we call biofilm. Biofilm are well known to be very resistant to antibiotics, and this biofilm can coat the biomaterials like implants or the tubings. So this organism are important in those biomaterial associated infection. So the development and persistence of those infections. So in the next slide there is a illustration of how this biofilm can be more resistant to antibiotics. We'll come to that in a second. So we're going to finish off talking about this, the third organism of Staphylococcus, called Staphylococcus streptophyticus. This is also a coagulase negative organism, but this organism mostly limited to urinary tract infection. So I think the urinary tract is a place where they hang out, so they can adhere to the epithelium of the urethra and bladder. So they're given the right condition, they can cause the infection in the urinary tract. So here's an experiment that performed by some scientists to show that biofilm cells are difficult to kill. So they have two biofilm. One on the left are not treated with anything. The second biofilm are treated with two antibiotics, vancomycin and rifampin. Vancomycin inhibits cell wall biosynthesis. Rifampin inhibits DNA synthesis. So they take that biofilm treated with vancomycin and rifampin for 72 hours at concentration exceeding the MIC and MBC for the organism. So MIC and MBC stand for minimum inhibitory concentration and minimum bactericidal concentration. So the difference between those two are basically one, it inhibit the growth, that's MIC. One kill the bacteria, bactericidal. Cidal means killing. So for every antibiotic, there are two values, two concentration. One is the MIC, one MBC against a particular organism. Typically, MIC value is higher than MBC. Sorry, the other way around. So you require less to inhibit and more to kill. So anyway, those are just people working in antibiotic resistant and so on. They have this sort of term they use to help them to describe the killing. So for your purpose, I think just remember those are concentrations that can inhibit or kill the bacteria. So they subject the biofilm to these two antibiotics much higher than the normal MIC MBC for 72 hours. Then after treatment, you can see that the picture on the right, there's still quite a few intact Staphylococcus epidermolysis cells that remain viable. So with that particularly high concentration of antibiotic, you cannot completely eliminate or kill those biofilm cells. So proving the point that biofilm cells are very difficult to kill. So what are the diseases caused by Staphylococcus? There are many. So you can group them under two groupings. One are cutaneous infections. This include localized skin infection like a carbuncle. That picture of the carbuncle on the top right there. And pimples, boils. So these are all localized skin infections. This sort of localized skin infection are easy to manage, so you can treat them with antibiotic, or the severe kind you can open or drain the pus and the liquid, and then followed by antibiotic treatment. Then you have impetigo. This is a contagious infection, particularly in young children. It's spread by a scratching, so it's kind of itchy. You scratch and you touch another surface, and then will spread that infection to that surface, or touch another person or another children. Another child, you will spread that to that child. Again, this is controlled by and can be easy by antibiotics. So there's a picture, a middle picture that is impetigo, or you can have score skin syndrome. This is brought about because they are obviously infection by Staph aureus that produce the exfoliative toxin. That toxin causing the dermis to separate from the underlying tissue, causing the bubble-looking infections. So there's a picture there, and this usually come with fever and skin redness and that sort of thing. So it's fatal in newborn, and also this is easily controllable by antibiotic ointment, and to prevent the spread, they can put the infected child or newborn in isolation. That way you can spread to other kids around. The second group are more severe. This deep-seated infection. So this could be in any area of the body. You have the bone, the joints, the lungs, the heart. They all are susceptible to infection by Staph aureus or Staphylococcus. So bone cells, they give you the osteomyelitis. In fact, Staphylococcus osteomyelitis is probably the number one disease in the bone infections. Then septic arthritis, so the joint got infected. The lung was given pneumonia, and then the heart itself can be infected by Staphylococcus, it's endocarditis. Can have infection of the blood, So that means talking about the blood now, long-term carry this organism. So it's not like temporarily presence of the staphylococcus in the blood, but long-term, that is no good, because then obviously the blood will carry the staphylococcus to many parts of the body. They can start the infection elsewhere, many areas of the body. So this is different from bacteremia. There are two terms here, one bacteremia, one is septicemia. Septicemia is the infection of the blood. Bacteremia is the term used for temporarily presence of bacteria in the blood. So the one is temporarily, one is persistent, a long-term present. So bacteremia, septicemia. Then you have a very severe infection called toxic shock syndrome. So remember that TSST toxin that I mentioned, the causing coming from a contaminated tampon, and this is one of them. So this way that the toxin enter the body, affecting multiple organs. So whether it's the central nervous system, hepatic, obviously the liver, and then your kidney, and the skin, etc. Multiple organs are affected by the toxin. So the toxin basically is causing our body immune cell to go on high gear. They produce tons of the cytokines and other immune components that lead to other condition. In this particular case will be adverse reaction. So I'm not sure you heard about the term called cytokine storm. So this cytokine are small protein that produced by mostly white blood cell. They're too much of it is no good. They sort of like control activate other immune cells. So too much activation lead to undesirable effect in the body. So the TSST have that ability to get the white blood cell to overproduce those cytokines, and that lead to start the process of this toxic shock syndrome. Then you have obviously drop in pressure, blood pressure, and so on and so forth. And in the picture here, you can see this massive damage to the person body from the hip all the way up to the arm, the chest, the side of the chest. This is a fatal case of toxic shock syndrome. So luckily this is not 100% fatal, can be treated, diagnosed quickly and treatment quickly. So fatal case is estimated to be 5%, and then but those who have contact will recover, but they have a higher risk of recurrent. Maybe the immune cell have have been primed, and then the next time around they'll be more quicker and more severe. So those are very severe infection caused by staphylococcus. So this last slide on this disease is illustrate that how widespread the organism is, and also the variety of different disease can be caused by staphylococcus. So the numbers there, 1, 2, 3, 4, refer to the isolation frequency. So always the larger the number 4 for some 90% positive coverage, I mean very commonly isolated from that type of disease. So you can look at the list on the left there: endocarditis, infection of the heart, staphylococcus score, skin syndrome, pneumonia, food poisoning, catheter infections, so the tubing that going into somebody's arms or the bladder, toxic shock syndrome, cutaneous infection, and then septic arthritis. So one organism is capable of causing this variety of disease in humans. So when we talk about Staphylococcus, we cannot avoid talking about antibiotic resistance, because Staphylococci is probably one of the well-known organisms that are resistant to antibiotic. So they are known for their ability to develop resistant to most antibiotic. In fact, one study showed that greater than 90% of the strain are resistant to beta-lactam antibiotic. Beta-lactam antibiotic refer to penicillin and other derivative for penicillin. So that is remarkable, because you have greater than 90% of strain are resistant to beta penicillin, other penicillin-like antibiotic that make penicillin basically useless. So maybe about 15-20 years ago, the drug company have come up with a new type of penicillin they call methicillin. So methicillin it's just basically a modification of penicillin. Penicillin have a lot of side change that can be modified so they become a slightly different penicillin. So methicillin, one of the last one they have developed, that is about 15-20 years ago. At that time when they come out, this methicillin come to the market, is very good in treating all Staphylococcus infection, but because that become a drug of choice, and you probably can guess, when you use a thing too much, the organism develop resistance. So now you have this MRSA called methicillin resistant Staph aureus. So the one of the thing about this resistance is that when we said they're resistant to methicillin and penicillin or beta-lactam antibiotics, but Staphylococcus, typically they're not only resistant to this antibiotic, they're also resistant to other antibiotics like tetracycline, clindamycin, erythromycin. All those have no use against the methicillin resistant or penicillin resistant Staph aureus. So there's only one antibiotic that is effective against this beta-lactam resistant Staphylococcus, that's vancomycin. So vancomycin, as you know, is an IV antibiotic, and given by IV, not like methicillin or penicillin can be taken orally. So there's another issue about that treatment, because it requires stay in the hospital and so on. But as you guess, when you use something often, they start to develop resistance. So they have found that methicillin resistant Staph aureus is also now resistant to vancomycin. Vancomycin, the last antibiotic available to treat infection by MRSA. So now you have doctors or physicians run out of any antibiotic to use. So that some scientists and medical people have said that this is a ticking time bomb, where when this vancomycin resistant, methicillin resistant Staph aureus becomes so widespread that then basically there are no means of treating people. So the resistant mechanism is mostly mediated by the production of an enzyme called beta-lactamase. So beta-lactam antibiotic, beta-lactamase, lactamase being an enzyme that breaks down the beta-lactam. So this gene, beta-lactamase gene, is typically carried on a plasmid. plasmid, a small piece of DNA that can multiply by itself and can be transferred easily from one cell to another cell. So therefore, that helps the spread of the resistance. So that's probably one of the common mechanisms of resistance. There are other mechanisms resistant to beta-lactam antibiotic, but this is one of the most common one by the spread of the plasmid carrying the beta-lactamase gene from one strain to another strain. Now we're going to switch gear to talk about Streptococcus. So Streptococcus is also a gram-positive cocci, but gram stain, you look under the microscope, appears as pairs or change, meaning that they have the cell joined together as one long change. You can see the picture on the right there. Now it's catalase negative. So remember the Staphylococcus a while ago we talked about that is a catalase positive. So in fact this particular test is a feature that a test that the microbiology lab in hospital will do to tell the two organisms apart. So we have a catalase negative organism, a gram-positive cocci in change, that most likely going to be a Streptococcus, not Staphylococcus. Now, Streptococcus also can be further divided into three groups based on hemolysis of blood agar. So the three types of hemolysis, obviously hemolysis is lysis of red blood cells. So you have beta, alpha, and gamma. So beta is complete lysis, and alpha partial, and then gamma no lysis at all. You can see this shown in the bottom left picture there. That is a blood agar plate that someone have inoculated the surface of the agar plate with three different bacteria. So someone being fancy to draw the letter alpha, beta, and gamma. So that is a good illustration of the type of hemolysis. So beta hemolysis, complete lysis. You can see the clearing surrounding the letter beta. So the word beta is basically a bacteria that have been inoculated in that sort of fashion, and then the alpha you can see sort of partially lysed, so a green color, and then the gamma no lysis at all surrounding the bacterial colonies. And you can see better in the picture on the right. So beta hemolysis and alpha hemolysis, these are agar, again blood agar plate have been streaked out. That you can see single colony, see how the halo or the clearing surrounding the beta hemolytic colonies, and versus the alpha hemolytic colony on the bottom, which is partial lysis. So this is very important test. You remember a while back in the first lecture we talked about the normal microbiota. In that table 1 that I pointed out to you, that in the oral cavity the streptococci are alpha and gamma hemolytic colony, right? So group A strep is a beta hemolytic colony. So if somebody have been suspected to have strep throat, which is called by group A strep, you take a sample from the throat area, you put on blood agar plate, right away you're going to tell there will be a lot of beta hemolytic colony, opposed to somebody who do not carry or are not infected by group A strep, then which is all alpha and gamma hemolytic colony. So it's a very quick, easy test the lab can do. So in fact, that's what they do when someone from suspected to have strep throat. they take the swab and put on a plate. You get a lot of beta hemolytic that will give you a piece of data suggesting the person has strep throat. Then obviously you further test the pick those beta hemolytic and do further testing, reacting with antibodies that originated from the scientist we talk about, Rebecca Lansfield, who initially used the antibody to put the streptococci into different grouping from A to S that we talked about previously. So those are the interesting thing about streptococcus. So the streptococcal pyogenes, we already mentioned some of this in the previous lecture. That is, humans, the reservoir found in the pharynx area, a beta hemolytic. We just mentioned that is a diagnostic test for initially looking at strep throat. Where do you find this? Obviously, person to person, through inhalation. The organism, just like Staphylococcus, produce a whole bunch of enzyme, toxin, and surface component. So, by the way, you don't have to memorize all the different enzyme and toxin and surface component. Same for the Staphylococcus part of this lecture. I just use this so to illustrate you heard about it rather than an empty word about they produce enzyme and toxin and surface component. So just get the idea that these organisms produce this whole bunch of different enzyme and toxin, enzyme lyse cells, and then toxin provides some of the symptoms. Then surface component help them to colonize this sort of thing. So these two organisms, Staphylococcus and Streptococcus, are equipped with all these important virulent factors. So diseases caused by Streptococcus pyogenes, so you can group them into suppurative infection and non-suppurative infections. Suppurative came from the word suppuration, meaning the formation or discharge of pus. So one of the symptom, one of the features of this infection, they always have pus being produced. So you can see the list there. You have pharyngitis, which is we commonly call strep throat, scarlet fever, which is the strep throat plus two other symptoms. There's a rash that we mentioned about on the chest and other part of the body, and then also the strawberry tongue that we mentioned. And obviously, scarlet, those symptoms, the rash and the strawberry tongue, are due to the production of a toxin called erythrogenic toxin by group A strep. Then you have other skin infection like pyoderma, episyphilis, and then more severe infections like necrotizing fasciitis. This is commonly called flesh-eating disease. This very severe destruction of the tissue and skin, muscle and fat layer, and there's a picture to show in the next slide, and this is a major destruction of the tissues, and can be and progress very quickly, then you have also group A strep also can cause toxic shock syndrome. So generally we specify it by saying that this streptococcal toxic shock syndrome, just like Staphylococcus, this is multi-organ being involved, and it's a lot similarly to Staphylococcus. Toxic shock syndrome is the toxin that getting the body cell to produce massive cytokines that lead to the body overreacting and leading to that the symptoms. So here a few three pictures on the disease. So you have impetigo, very similar to a staphylococcus lesion on the facial area. Erysipelas is more of a reddish and rash kind of thing, and then necrotizing fasciitis. You can see this person leg, the level of destruction, and when this happens, this can progress from within 2 or 3 days from the initial infection. So this is a very severe disease, and a lot of time end up with either death or amputation. So it's the same organism causing strep throat, but why it got in some cases like this here causing such a massive destruction is still not do not know why the difference. Why you have impetigo or erysipelas compared to this necrotizing fasciitis, is quite a contrast, and it's caused by the same group A strep organisms. So that is a question that scientists and medical doctors cannot figure it out yet. So then you have the non-suppurative infection. This refers to rheumatic fever. This post-streptococcal infectious disease. So the word is post-streptococcal means that the person's already recovered from the streptococcus infection. So the person may start out with a scarlet fever or strep throat, or even a localized skin infection, and your body have won the battle, and group A strep have been eliminated from the body, so no living streptococcus pyogenes in the body. So this is afterwards. So the post-streptococcus. That means the cause of this rheumatic fever is not due to streptococcus pyogenes direct infection. Rather, it's to some other mechanisms, which scientists have put forward with three theory. One is direct destruction. Second is serum light sickness. Third is autoimmune reaction. So direct destruction means that there are enzyme and toxin produced by group A strep that lead to some damage to the tissue because the bacteria have been killed and gone from the body, but those enzyme and toxin remain in the body, continue to do that destruction. Serum light sickness is antibody antigen complexes. So you have antibody being developed, raised during the infection. So those antibody will remain in the body for a while, but the group A strep gone, but part of the bacteria still remain. So whether it's a protein, whether it's a cell wall, they remain in the body circulating. So antibody find them and bind to them, forming a complex, and that deposit onto the body tissue, whether it's the joint or the kidneys or the heart surface or some other subcutaneous tissue, leading to the body reacting to it. So that's the second theory. The third one is autoimmune reaction. This is that the group A strep have antigen or protein that looks similar to our body tissue. In fact, they have shown that scientifically the membrane of group A strep have a protein that is very similar to the myocardial antigen. So the one antigen on our heart is very similar to group A strep, one of the membrane protein in group A strep. So they think that the antibody raised during the infection will come and when a group H strep is gone, the antibody remain and then come and found the myocardial antigen and bind to it, and then your body trying to rid of that and repair that antibody bind to your own tissue, and that lead to damage to that tissue. So, and that's the autoimmune reaction seem to be, most people believe that is the cause. That's the reason behind the post-streptococcal infectious disease, in other words, rheumatic fever. So obviously, rheumatic fever can happen in many parts of the body, the heart, the joint, the kidney, and subcutaneous tissue. But if it's on the heart, we call it rheumatic heart disease. Then you have glomerulonephritis. This is specifically talking about the kidney being having this rheumatic disease, and there seems to be a different when you have a streptococcus skin infection that will sort of link to the glomerulonephritis. Rather, you have a rheumatic heart disease mostly to the infection of the oropharynx. So strep throat and scarlet fever seem to tend to have that sort of association with rheumatic heart disease. The reason why for that, and nobody has figured it out yet. For treatment of group H strep infection, penicillin is still the drug of choice because group H strep is still, by and large, quite sensitive to penicillin. For patients who are allergic to penicillin, they can use erythromycin. So then, obviously, related to relevant to dentistry, that a person who are known to have rheumatic heart disease, then dental treatment had to be performed according to the AHA, American Heart Association guideline that you have a copy down in the clinics. So this involves using antibiotic on the patient during the dental procedure. So they here's a prophylactic antibiotic prior to dental procedure. I think that no longer true. The latest AHA guideline is to don't give the only give antibiotic after the dental procedure. You can check on those on the AHA guideline. So that would lead us into infective endocarditis. So this is basically refer to infection of the endocardium, heart valves, or septum. So endocardium is a thin and delicate membrane lining the heart valves and the heart cavity. So is that membrane got infected. So there are two types of infective endocarditis, acute and subacute. So the picture here shows the heart valves that have been infected. The yellow mass that they pointing to, those are actually your vegetation. The vegetation consists of your own body cell like platelets and fibrins, proteins, and then also a lot of bacteria. So bacteria, platelets, fibrins that make up that vegetation, they're sort of sitting on the heart valve. So there are visible mass on that heart valve, and person have endocarditis. So the difference between acute and subacute endocarditis is that there are that obviously is the speed of the disease. So acute is rapidly progressing, while subacute endocarditis slowly progressing. So there's 6 weeks versus 1 or 2 days in acute endocarditis. So that's one difference. The second difference between the two is that the stage of the heart valve or the heart surface. So acute endocarditis can develop on normal heart valves or prosthetic valves. Prosthetic valve is somebody have a replacement heart valves that are not quite working properly. Like for example, it's not open and closed properly, and that could be a condition for acute endocarditis. And then in subacute endocarditis, it almost always involve a damaged heart valve. So damaged heart valve, that means there have been scarring that come from your rheumatic heart disease. So a person have scarring of the heart valve because of group A strep infection, and that scarring or damage will give the condition for bacteria to come and bind to and start the infection. So the third difference is the type of organism that it involves. In acute endocarditis, usually a more virulent, considered to be more virulent organism like Staph aureus or some other virulent streptococci like Streptococcus pneumoniae. In the case of subacute endocarditis, usually a less virulent organism like those found in the dental plaque, the oral streptococci, or sometimes we call them very dense streptococci. These samples are Streptococcus aureus, Streptococcus sanguineus, Goodonii, and Mitis. These four organisms are very common organisms found on the dental plaque, so they are sort of considered to be relatively harmless organism. These are parts of the normal microbiota found in the oral cavity. But these organisms have been shown to have the ability to bind to the heart tissue and platelet, and in clinical cases they have been isolated from the vegetation of people who have subacute endocarditis. So the organisms are different, the speed of the disease is different, and then the state of the heart valve or heart surface is different. Those are the three main difference between the two type of endocarditis. Now, subacute endocarditis can also be caused by many other bacteria, but the oral streptococci are more common, so other organisms can capable of causing it, including Enterococcus and aggregated bacteria, or in the particle Actinobacillus, and then Bacteroides and Haemophilus. So the other bacteria in the body are capable of causing subacute endocarditis. So the pathogenesis of subacute endocarditis depends on two factors. One is bacteremia, and second is susceptible heart tissue. So bacteremia is the presence of bacteria in the blood. So this happens all the times in humans. So in a given day, you're gonna have bacteremia. That can come from there's breakage on the mucous membrane. That could be from chewing a hard candy, for example, or frothing, or even from bowel movement in the intestine. So those bacteria get into the bloodstream, and they will be clear quickly. Say within 30 minutes or so, the immune component, the white blood cell, will come and gobble them up, and then will destroy them. So this is a temporary presence of bacteria in the blood. So that happen all the times. So the susceptible heart tissue for these bacteria that get into the blood able to colonize. So that heart tissue becomes susceptible. That can come from rheumatic heart disease, we already mentioned that, or coming from congenital heart defect, people who are born with some defect in the heart. For example, valvular insufficiency, that is like the heart valves are not sufficient. That means that it's not long and not shorter than normal heart valve. So the open and close of the heart valve did not close all the blood flow. So that influenced the flow of the blood from the heart to the artery or aorta, and that creates turbulence. So it's the turbulent flow of the blood that deposit particles, including bacteria, on the back of the heart valve that promote that colonization process. Or other congenital heart defects like intracardiac shunt, where they have opening in the septum. So congenital heart defect can lead to that susceptible heart tissue, or history of cardiac surgery, person gone into surgery of the heart, whether it's repairment of the heart valve and that sort of thing. And then you have syphilitic aorta. This is not common now, but in the old days, quite common. That's actually referred to syphilis, a sexually transmitted disease caused by the spiral key. And we talk more. We have a lecture on the STD coming up next week. We'll talk more about that. But it's known that in syphilis, in the later stage of this STD, the heart valve or the aorta can be damaged, and that create that condition of damaged tissue for the bacteria to colonize and bind and cause infection. And then the last one here, number 5, I put a question mark on the use of fenfluramine and phentermine. This is the two drugs that have been used to control body weight. People who cannot lose their body weight, they can take these two drugs to help to control the body weight. And there is a report by CDC way back that there is a link between this and the development of damaged heart that could lead to a person to get subacute endocarditis. So here's a picture form of the pathogenesis. So on the right you have the acute endocarditis, on the left is subacute endocarditis. So the main difference is the shown on the diagram is the condition of the endothelium of the heart. So of the heart tissue. So you have normal endothelium. It doesn't require any previous damage to the heart tissue. And then in the subacute endocarditis, you have the scarring, a traumatized endothelium that will lead to the body respond to by recruiting in cells like platelet cells, and then also to deposit fibrins onto that traumatized endothelium, and that lead to a development of the vegetation. At this point, the vegetation will be sterile. So sterile, there are no bacteria there yet, so it's just an own body cell and body component like fibrin that deposit onto that traumatized endothelium. Then the next factor you need is bacteremia. So now your bacteria got in the bloodstream, whether from dental procedure or from other means. So those bacteria now circulated and find the surface. And then in the subacute endocarditis, they have this vegetation allow them to bind to, and then they start to multiply, and then more platelet, more fibrin gonna put down, and more bacteria either come from bacteremia or those already there start to multiply. So that vegetation now is not sterile, but also getting bigger, so that eventually pieces of that vegetation going to break off, and then will send off by the blood to different area of the body, and can be landed in small capillary, like in the brain or some other vital organ, and then start the infection there or block up the circulation. I think this is the reason for subacute endocarditis in killing person is that embolization. That's the small fragment of that vegetation got broken off, sent off to different vital organ of the body. So in the case of acute endocarditis, the bacteria get into the blood is more virulent, like Staph aureus or strep pneumoniae, so they can bind to the non traumatized endothelium directly, and that lead to colonization, and then your body trying to fight it off will recruit in platelets and other things, and that start that vegetation. So the end result is the same. You have embolization and so on. So here's a report by CDC, an alert actually from CDC back in 1997, alerting the dentists and dental school in North America about patients who taking these two drugs, fenfluramine and phentermine, that they have high 77% can have this valve have been looked to be some damage to the heart valve, and obviously that is one of the conditions that can lead to subacute endocarditis. I have not been following up on this front, but you should keep that at the back of your mind, or you can look it up and see whether that's still the concern by the CDC. So to treat endocarditis, basically antibiotics like penicillin are quite effective. Then you can go on other antibiotic if a person are not penicillin is not suitable. That's true for both acute and subacute endocarditis. So then, obviously, in dentistry, if a person who are known or suspected to or confirmed to be having rheumatic heart disease, that obviously you need to confirm that with the patient physician to confirm that, or have a heart murmur, that sort of thing. Then you have to treat your patient with this AHA guideline that previously mentioned. So the use of antibiotic in this at-risk patient, the idea is to kill circulating bacteria in the blood that can happen. That obviously going to happen during then the procedure, So the general principle to prevent the infective endocarditis sort of listed in the table here. Obviously, maintaining a good oral health is important. So that will reduce the bacteremia. So your good poor oral health, obviously going to be a lot of bacteria in the plaque or in the gum tissue. That obviously increases the chance of bacteria getting into the bloodstream. Even simple things like chewing a hard candy or chewing hard food, you have a lot of bacteria or a lot of dental plaque that can just increase the risk of getting bacteremia. Or you can reduce the need to operate it than the treatment. So the thing doesn't need to be undergo operation. You can other means to treat the patient. You go with that instead of operation. Then you prophylactic antimicrobial agent you can go to, like the commonly used Cohexidin mouthwash. So before the dental procedure, even simple things like planning and cleaning, you can have the patient get this oral rinse with Cohexidin. The idea is that Cohexidin can kill this microorganism quickly, so can reduce the microbial load in the oral cavity, so that reduce the risk of bacteremia. Then you have obviously prophylactic antibiotic coverage, and I already mentioned that the idea is to kill those bacteria already got into the bloodstream, so that will help to prevent that subacute endocarditis to occur. So this is our last slide, and next week we'll look at STDs and central nervous system infection.